All right. It is great to be here. Thank you, everyone, for joining me and my brother. I'm excited to talk about the retinal uses of some of ZEISS's latest diagnostic imaging equipment. And I know Jeff will be talking about the glaucoma, how he finds it useful on the glaucoma setting. When I first started talking with Kevin and the folks at ZEISS, Jeff and I imagined something akin to the Blues Brothers. Of course, we pitched it as the Goldberg brothers, with Jeff talking about glaucoma and me talking about retina. So I am a researcher and work with ZEISS over the last almost half dozen years now to develop the next generation of equipment. And so I am going to quickly talk about the CLARUS 700, which is ZEISS's ultra wide field imaging and angiography equipment, and the CIRRUS 6000, which is their latest spectral domain OCT and OCT angiographer, and what some of the key upgrades are. And I want to spend most of the time talking about some case examples of how I use some of these different imaging modalities in my routine management of retinal patients. So the CLARUS 700, for those of you who haven't seen it, it looks much more like a traditional kind of old school fundus camera, even though it is ultra wide field. It's got a very familiar design. And I think the key innovation here is that it captures true color images with very high resolution. So it does not use a scanning laser ophthalmoscope. Instead, it uses these 3 LED light sources, a red, green, and blue LED. And it something that ZEISS invented called broad line fundus imaging, where it basically captures a 130-degree image of the retina in 0.2 seconds, and it kind of scans through the retina. And there's also an IR light source, infrared, which gives you a real-time preview of the photo you're taking. So it gives you 133 degrees in a single capture. And then in what they call ultra wide field mode, it auto montages 2 images automatically to give a 200 degree image. And you can actually merge up to 5 images. You can image through non-midriatic undilated pupils. You need about a 2.5 millimeter minimum pupil size. And I think the key thing with this is that even though you're getting this really wide field image, you don't sacrifice any of the resolution, which they say is down to 7 microns. And so here's the same image. I haven't kind of switched a lens. I've just literally zoomed up digitally, and you can see the great quality of the fundus photos. And I think this is really important actually in a multi-specialty setting, for example, like where you've got retina and glaucoma, because you can take really high quality optic nerve photos with the CLARUS, which is what your glaucoma specialist wants. You can actually take stereo photos even. Jeff can comment whether glaucoma docs are still using stereo photos or not. And you get what you need for the retina specialists as well with the wide field and angiography capabilities. So it addresses, I think, some of the drawbacks of the legacy ultra wide field system, which uses a red-green scanning laser ophthalmoscope and doesn't give you true color images, but what we call kind of pseudo color or lower resolution images. And so you really, with the CLARUS, you don't need to keep your traditional 45-degree fundus camera. It also gives you a great usable field of view. The CLARUS has partial confocality, which greatly reduces the lid and lash artifact that I think many of us in retina are used to seeing with the SLO wide field system. It's got great patient ergonomics. Unlike a fixed camera where you have to literally grab the patient's head and move the eye to the focal point, here, like a traditional camera or like an OCT, you keep the patient's head stable and you move the camera back and forth to focus it. And so I think this leads to improved patient comfort and easier image acquisition. And then regarding the image acquisition, the CLARUS gives you a live infrared preview. So you get a very, you know exactly what the photo is and the image is and what you will be imaging with every attempt of the photograph. So I think you need fewer attempts because you know exactly what you'll be capturing with each photo. The CLARUS 700, which was the upgrade from the original CLARUS 500, which launched first, adds FA and ICG angiography. They've got a couple different what they call precision focus and auto bright and gaze point. And I like to joke that when you work in marketing, you kind of take two words and you eliminate the space from them, and now you've got a marketing term for something that focuses precisely or adjusts the brightness automatically. So anyway, the CLARUS has all of these nice features here, which again, just add to the ease of use. And I love showing this picture. This is one of my technicians. She can do photography. She's not a certified ophthalmic photographer, but this was her taking images with the CLARUS, literally with no training. It's just a very user-friendly design, and kind of within 5 minutes, she was up and running and imaging patients. So I love the ease of use here with the CLARUS. So here are some just beautiful images. This is from a patient with an ischemic branch retinal vein occlusion. If you zoom in carefully, you can see the incredibly high resolution. Again, I'm not taking a separate photo here. You just zoom in to various parts of the image to capture what you want. Here's a patient with a very interesting case, actually, with Eales disease. You can see this is the single shot image here, very high resolution. You can see the ischemia, the telangiectasias that are present, and really the demarcation between perfused and non-perfused retina. Here's what it looks like, let's say, if you wanted to auto montage a couple of the images and get further afield. Here's a great patient with proliferative diabetic retinopathy and intraretinal microvascular abnormalities. We zoom in here, and you can kind of see it on the FA, but we zoom in more closely, and you can see it very clearly, the details. And then this is actually the very first patient I saw and imaged on the CLARUS. This was an experimental CLARUS 700 with FA. And we actually, the service technician from ZEISS who's helping to set it up, undiagnosed sickle cell disease, excuse me. But we saw these images and we just kind of testing the unit, and we said, oh my gosh. And I took a look at them, and lo and behold, here are his images. Again, this was with the very first patient I imaged with the CLARUS 700, and sent him to his primary care physician and diagnosed him with sickle cell disease, which he had not known he had. Here is his structural OCT, and you can see a little bit of thinning temporally there. When you see that thinning, of course, you're thinking about, if you're a glaucoma specialist and you see interretinal thinning, you're thinking about nerve fiber loss. But when you're a retina specialist and you see interretinal thinning, you're thinking about ischemia. And sure enough, when we do the ZEISS angioplex, the spectral domain OCT angiography, we see capillary dropout in the inner and outer retina. Here's though just showing the fovea. His foveas were intact. His vision was excellent, thankfully. He's doing quite well from a visual standpoint. But you can see, just comparing the OCTA to the CLARUS FA, the resolution, frankly, on both devices is phenomenal. And then for those of you who don't know, ZEISS has launched as well a update to the CIRRUS 5000, which I think for a long time was the standard of care for spectral domain OCT. They've upgraded it, basically giving you a lot of the features of swept source OCT in a spectral domain device. So they've increased the scan speed. It's up to 100,000 A scans per second, faster OCTA scans. All of these things allow for wider field montaging or just single capture OCT angiographies. And I'll show you some of those images up ahead. So you can capture 100,000 A scan cubed in as little as 0.4 seconds. You can actually go up to 12 by 12 millimeter wide scan. And then they have this new feature because of the increased scan speed that they call HD OCT angiography, and I'm going to show you a little bit more about this. So on a traditional angioplex on the ZEISS CIRRUS 5000, which had 68,000 A scans per second, your choices were a 3x3, a 6x6, or an 8x8 millimeter scan. And they had pros and cons. I used to tell people, hey, for a CNV disease, get the 3x3 millimeter scan because you want the higher resolution. But for patients with diabetes or retinal vein occlusion, get the 6x6 or 8x8. Because when you zoom in on a 6x6 or 8x8 scan, and again, this is taking the 6x6 or 8x8 millimeter scan, but just looking at the central 3 millimeters, you can see you have a significant resolution drop off. Well, the great thing about the CIRRUS 6000 is that it eliminates this resolution drop off by the faster scan speeds and by some image averaging technique they have. So you can now just get a single scan pattern, let's say the 6x6 or the 8x8, for all your patients. And I find this very efficient with technicians because I don't have to tell them, oh, do a 3x3 on this patient or a 6x6 on this patient. Now they can just get the 6x6 HD scan, and I know I'm going to capture everything I want. So here you can see some of the resolution, comparing the traditional 6x6 to the new HD scan, 12 micron lateral resolution. And it also adds some of the wide field imaging and montaging that was present on swept source devices. These are the images you often see presented on podium, but now they're kind of available on a routine basis in the spectral domain platform. So here's a patient, a 74-year-old Hispanic gentleman who's referred for wet AMD in the left eye. He's 20/30. You can see most of the action here just on the color photo is below the fovea. And here's his structural OCT at the time of presentation. He's got that large PED with subretinal fluid. His fovea is actually intact, which is why his vision is still good. He received 6 monthly injections, but still has this chronic fluid, and I actually brought him over so I could do OCT angiography. And here you can see the 6x6 angiography, the ORCC, the outer retina to choriocapillaris segmentation, shows the choroidal neovascular membrane that's present infranasally. Sometimes these can be hard to interpret, until you get better at looking at them. I find looking at the B scan with flow overlay is actually more important because you can scroll through like a traditional B scan image, a traditional volume scan, but it shows you where the machine is detecting blood flow. And so you can see that that flat PED is clearly vascularized because that's where we see the flow in red. And then when we look at that large PED, well, there's a big blood vessel going right through that. And this patient has polypoidal choroidal vasculopathy. And that's why the fluid has frankly been recalcitrant inferiorly. Thankfully, he's done well because this was below the fovea. And then here's a patient who I'd seen actually in 2016 with chronic central CIRRUS, 20/30 vision. Those are the 2016 scans. Was lost to follow-up, but came back in August of 2019 with new distortion in the left eye. And now where there had been just kind of CIRRUS subretinal fluid, we see this, what you might call subretinal hyperreflective material or vitelliform material. I was certainly thinking, could this be vitelliform, a vitelliform lesion? There is some subretinal fluid superior to the vitelliform lesion. I got an autofluorescence, which I think really is the standard of care for diagnosing adult vitelliform macular dystrophy. But I still wasn't 100% sure, given the subretinal fluid that was also present, could there be a CNV there? And what are your options? You could do an FA or an ICG, but these are invasive and require a skilled photographer. And frankly, they're often equivocal. I think in my old days, I would have done a diagnostic challenge with an anti-VEGF injection where I gave them an injection and just saw them back 2 weeks later and said, hey, did the fluid or subretinal hyperreflective material resolve? But this is invasive and it does carry some risk. So I was able to perform an OCT angiogram. And here you can see kind of the 6x6 retinal scan, the ENFA. So that gives you the entire retina down to just above the RPE. And we don't see any abnormal flow there. So that's certainly a good sign. But you scroll through some of the different segmentations, and on the right side, you see the 6x6, what they call RPE to RPE fit line. And you look at that and you say, is there something going on there, or is that just a projection artifact? And again, here's where I find the B scan with flow overlay so critical, because we look through the B scan and we don't see any flow through that vitelliform lesion or where there's subretinal hyperreflective material. And so we know that this is indeed adult vitelliform and that there's no evidence of choroidal neovascularization. So I really like to combine kind of the benefits of ultra wide field and OCT angiography for non-invasive imaging of kind of both inside the retinal layers and outside the macula. And I'm just going to quickly speed through two more cases here. Here is a case, a patient with a CRVO, 2400 vision, gets one Eylea injection of aflibercept. You can see marked reduction in the fluid, gets 3 monthly of aflibercept. And really here, we don't see on the structural OCT significant retinal thinning, but there's no improvement in the visual acuity. What's going on? Well, it's not a blatantly ischemic retina on the structural OCT, but when we do the, this is a swept source OCT, when we do the OCT angiography, here both the superficial and deep capillary layers show marked capillary dropout with an enlarged and irregular foveal avascular zone. And this is really the reason why the patient isn't seeing better. And I can use this then to help titrate and adjust how much therapy I need to give this patient, given that I'm not going to be able to get the vision better than about 2400. And here's helpful case number 2, a 54-year-old Caucasian woman. I kind of inherited her from another retinal doctor. She'd been receiving monthly aflibercept in the right eye for wet AMD and was diagnosed with geographic atrophy since age 38. And of course, when you see GA in someone under 50 years old, a red flag should go up in your mind that something's not quite right here. Here are her images on the CLARUS. You can see just some kind of pigmentary changes in the right eye. Here's the left eye. Again, zooming in on that same wide field image, we do see a kind of a atrophic geographic lesion here in the left eye. And here's the right eye. There's a shallow PED. There's a thick choroid. There is some subretinal fluid. And this fluid kind of had a waxing and waning component. And some of it seemed responsive to aflibercept, but some of it frankly didn't. FA, as can often be the case, was indeterminate here, didn't really see much. ICG, again, here's the CLARUS ICG. Zooming in, don't really see anything definitive here, at least nothing definitive that I can see, but on the OCT angiogram, we see that kind of snake-like curly Q vessel. This is down in the choriocapillaris lab. And again, the B scan with flow overlay right there in the center where there's that shallow PED, we see clear choroidal neovascular membrane. So when I put this all together, I say that this is, you know, what they now call pachychoroid spectrum disorder. I think the left eye probably had a collapsed PED, which collapsed into an area of geographic atrophy. And the right eye has this pachychoroid disease with exudation, with a secondary CNV. So some of that subretinal fluid is VEGF responsive, but some of it isn't. And so it's helpful to have all these images to be able to diagnose this case and properly manage her. So I thank you, and I welcome any questions you might have.